A 5-year-old girl was admitted for persistent fever and cough. She also complained of breathing difficulty. The blood culture was negative and sputum culture grew only commensal organisms. But a chest radiograph showed collapse consolidation. The girl was initially treated for pneumonia with a 3rd-generation cephalosporin. However, the middle and lower lobe of her right lung showed persistent collapse, as revealed on a chest X-ray. In addition, a CT scan of her thorax showed collapse of the right middle lobe and consolidation of the right lower lobe. These results were characteristic of the rare Swyer-James-McLeod syndrome. This syndrome was first described by Swyer and James in 1953 in a 6-year-old patient with recurrent respiratory infections. The girl in the case study we are reviewing was then discharged with routine follow-up visits. 4 years later, she was diagnosed with pneumonia caused by Haemophilus influenzae. She was successfully treated with cefuroxime and her lung collapse was resolved 3 months later. She has been well now for the past year. Cefuroxime belongs to the 2nd generation of the cephalosporin family, which has a beta-lactam ring. Cephalosporin was discovered by Professor Giuseppe Brozzu in 1945. The organism that produces cephalosporin is the fungus Cephalosporium acremonium, now known as Acremonium chrysogenum, which Brozzu isolated from water taken from a local sewage outfall in Sardinia, Italy. The development of cephalosporin was subsequently led by Sir Edward Abraham of the Florey team, the same team which first studied penicillin. So, how does cephalosporin work against pathogenic bacteria? Its mode of action is similar to other beta-lactam antibiotics. Cephalosporin first crosses the cell wall of a bacterium and binds to the penicillin-binding protein. Binding will disrupt the synthesis of the peptidoglycan layer of the bacterial cell wall, leading to its lysis. Compared with the 1st-generation cephalosporins, cefuroxime has enhanced activity against all major pathogenic aerobic bacteria, including both gram-positive and negative bacteria. Cefuroxime is available in the oral form, known as cefuroxime acetyl. When ingested, cefuroxime acetyl enters the gut in its esterified form and then undergoes rapid de-esterification by non-specific esterases in the intestinal mucosa. This causes the release of the active parent compound cefuroxime. One of the many reasons why Zinacef and Zinnat have been the mainstay treatment for infectious diseases is because of the dual mode of drug administration. Sequential therapy from intravenous to oral cefuroxime is often successful because dosing regimens are flexible and convenient, patient adherence is high, and there are minimal adverse reactions or side effects. Twice or thrice daily intravenous Zinacef, followed by twice daily oral Zinnat, successfully treated more than 80% of patients with community-acquired pneumonia. Sequential therapy of Zinacef and Zinnat also resulted in cure or improvement in nearly 90% of patients with acute exacerbations of chronic bronchitis. On the whole, a twice dosing schedule presents a simpler and more convenient treatment regimen. Empirical therapy for acute bacterial sinusitis must be effective against Streptococcus pneumoniae, Haemophilus influenzae, and Moricella catarrhalis. In studies, twice-daily Zinnat resulted in cure or improvement in 92% of children aged 5 to 14 years who had acute bacterial sinusitis. And in the course of treatment, only 2.5% of patients suffered from gastrointestinal discomfort. Twice-daily Zinnat resolves skin and skin structure infections in children. The primary pathogens in these kinds of infection are Staphylococcus aureus and Streptococcus pyogenes. Research has shown cure or improvement in 97.8% of Zinnat recipients. It was also shown to be highly tolerable, with only 7.9% of children experiencing adverse events. Prophylactic antibiotics were introduced in the 1960s. Staphylococcus aureus alone accounts for about 40% of surgical wound infections. Zinacef is effective against Staphylococcus aureus and is often used in combination with metronidazole for anaerobic bacteria cover. Zinacef is one of the most commonly used antibiotics for surgical prophylaxis in the US and UK. The Surgical Infection Prevention Guidelines in the US recommend Zinacef for prophylactic use in hip or knee arthroplasty and cardiothoracic and vascular surgery. In biliary tract surgery, a single prophylactic dose of Zinacef given before an operation reduced wound infection to between 4.6 and 6.6%. In vascular surgery, the common pathogens are Staphylococcus aureus or Staphylococcus epidermidis and Pseudomonas aeruginosa. In one study of patients receiving Zinacef as prophylaxis in vascular surgery, the wound infection rate was 9.1%. In colorectal surgery, contents of the large bowel are a potent risk in surgical wound infection. Generally, 40% of patients will develop post-operative wound infection in the absence of antibacterial prophylaxis. Combination therapy of Zinacef and metronidazole resulted in a low infection rate of 7.3%. In cesarean sectioning, endometritis or wound infection was 2.5% for those who received Zinacef prophylaxis, a stark contrast to the 29% observed in patients on placebo. Combination therapy with Zinacef and cefadroxil, a first-generation oral cephalosporin, reduced infection by 33% compared with patients who did not receive any medication. Also, non-infected patients had a significantly shorter stay in hospital, 8 days compared with 12 days. The ability of cephalosporins to penetrate bone and soft tissue makes Zinacef an effective prophylaxis for orthopedic surgery. Staphylococcus aureus and Staphylococcus epidermidis were the most frequently isolated pathogens. A single day's dosing with Zinacef reduces the rate of deep wound infection in primary hip arthroplasty patients to 0.5%, compared with 1.2% in those who received 3 days of cefazolin. In coronary artery bypass surgery, a single dose of Zinacef is sufficient to sustain adequate levels of prophylactic antibiotic throughout the operation and for a few hours thereafter. With this regimen, the infection rate was maintained at a low 4.9 to 5.6%. In fact, data on post-operative infections in adult patients undergoing isolated coronary artery bypass surgery between 1994 and 2003 in Greece show that single dose of Zinacef remains effective and safe despite its continued use. So, Zinacef could be used for single-dose prophylaxis without the increased risk of resistance problems. Zinacef has excellent CNS penetration and is able to penetrate the blood-brain barrier in proportion to the degree of inflammation. In one large study using Zinacef prophylaxis, post-neurosurgery infection rate was 0.3% by the time of discharge. Zinacef and Zinnat remain the preferred choice for infection prevention and treatment. There are 4 important reasons for this. Their broad spectrum of activity makes for excellent surgical prophylaxis and treatment. Their ability to be given as a short course of treatment reduces the length of hospital stays and the risk of antibiotic resistance. They are ideally suited for use in sequential therapy, which improves patient comfort and adherence. And lastly, they have an excellent tolerability profile with minimal side effects.